Good morning, all of you. Today's lecture or interaction, we are going to study about the other motility disorders like diffuse esophageal spasm, other diverticular diseases of esophagus. We are going to cover all these things. And the last interaction, just to remind all of you, we have studied the motility disorders, especially about the achalasia. And in this interaction, let's start with the other possible disorders. Hope all of you are safe. So let's start with diffuse esophageal spasm and diverticular diseases of esophagus along with other motility disorders. In general, we can divide these motility disorders of esophagus apart from achalasia, we have already studied, into basically three broad groups. The first group is the disorders affecting the Pharyngo Oesophageal junction. Second group affecting the body of the esophagus, and in this group, the first one, the Pharyngo Oesophageal junction, the one of the example is Zenker's Diverticulum. Zenker's Diverticulum. Now in body of the esophagus, the disorders, the various disorders we are having is diffuse esophageal spasm, important one. Few important things regarding Nutcracker esophagus, important from PG point of view. And the third subgroup in disorders affecting the body of the esophagus is esophageal diseases involving autoimmune processes or autoimmune diseases. They are occurring as a part of autoimmune diseases. So in these two broad groups, these are the important conditions. And the third group is the diverticular diseases, the pharyngeal and esophageal diverticula. Where is diverticula? Zenker's diverticulum, the mid-esophageal diverticula, the epiphrenic diverticula, and diffuse intramural pseudodiverticulosis. As in this, again in this broad group, we are having Zenker's diverticulum, and in the first one, this Zenker's diverticulum also affects the Pharyngo Oesophageal junction. According to the site of the disease, throughout the esophageal length, starting from the cranial to caudal end, in this group, we are having Zenker's diverticulum, followed by mid-esophageal diverticulum, then epiphrenic diverticula affecting the lower esophagus, and this diffuse intramural pseudodiverticulosis of the esophagus usually affects the lower part, but yet, yes, it may happen anywhere throughout the esophagus. So this was the broad classification of other motility disorders of esophagus apart from this achalasia. So let's start one by one. First of all, the disorders of the pharyngoesophageal junction. Very brief. The disorders of pharyngoesophageal junction, the patients are usually complaining of oropharyngeal dysphagia. And this oropharyngeal dysphagia, broadly speaking, they are seen in two groups, two major conditions. The first one is Zenker's diverticulum, and the second group is the patient is suffering from some generalized neurological or muscular disorders in which the pharynx and pharyngeal muscles are involved. This area is involved. So these are the two broad groups where this oropharyngeal dysphagia can be seen. In detail, we will discuss in diverticular part. As far as the treatment of this disorder, this Pharyngo Oesophageal junction diseases are concerned, few important points just I am discussing here. Suppose the patient is suffering from cerebrovascular accidents. In these type of patients, if they're complaining of pooling of saliva, and during the night time they are usually going to aspirate, so just to stop these complaints, sometimes these patients may benefit from the myotomy of cricopharyngeus muscle, the cutting of the muscle, myotomy of cricopharyngeus muscle to release. But the important thing is only these the two things are there. They must have good deglutition process and phonation. If these two things are there, then only we are going to opt for myotomy. Otherwise, this is not going to benefit that patient. So remember, any patient suffering from a disease affecting pharyngoesophageal junction after, let's say, cerebrovascular accidents, the hemorrhage, intracerebral intracranial hemorrhage, may be hypertensive or traumatic sometimes. If they are having good deglutition and phonation, adequate phonation is there, then only myotomy should be done. Sometimes the myotomy is also effective if patient is suffering from oculopharyngeal muscular dystrophies. There are various muscular dystrophy, again the disorders affecting the nervous system along with muscles, especially muscles, and affecting the ocular area and as well as the pharynx. So these patients sometimes may benefit from this treatment, the surgical treatment, myotomy, in diseases affecting the pharyngoesophageal junction. Later on, the clinical features, when we are going to discuss the Zenker's diverticulum and diverticular diseases, we'll go through the clinical symptoms and in detail the treatment part also, the relevant one. The second broad group was disorders of the body of the esophagus. Now in this group, we are having four important things. The first one is diffuse esophageal spasm, the Nutcracker esophagus, autoimmune diseases affecting the esophagus, and Eosinophilic esophagitis. These are the broad four groups we are having in this disorders of the body of the esophagus. Let's start with diffuse esophageal spasm. Basically, there is incoordinate contractions of the esophagus, and that incoordinate contractions, they are causing difficulty in swallowing, and along with chest pain, may or may not be associated with chest pain. So one of the important differential diagnosis of this diffuse esophageal spasm should be to rule out cardiac cause, angina or myocardial infarction sometimes. Now, on esophageal manometry in these type of patients, there is spastic pressure between 400 to 500 millimeter of mercury, very high pressure. That's why diffuse esophageal spasm, the condition is known as. On endosonography, there is the circular layer, the muscle layer of esophagus markedly hypertrophied on endosonography. And on barium swallow, a corkscrew esophagus is seen. Again, very important point regarding your PGME preparation after passing out this MBBS. Now, how does this corkscrew esophagus looks like? It's somewhat like this. If you can see here, this is just like a screw-like structure, The whitish structure you can see here, contrast. This is the esophagus. There is the diaphragm. Now, can you see here? It's almost similar to a screw-like structure. That's why known as corkscrew esophagus. This is classically seen in diffuse esophageal spasm. And distal two-thirds of the esophageal body is usually affected, and these abnormal contractions are more common in distal two-thirds of the esophageal body, very less common in upper one-third of the esophagus, these abnormal contractions. So diffuse esophageal spasm, as you already just you have seen, is basically the lower part of the esophagus, distal two-thirds is basically involved in this diffuse esophageal spasm. An amazing picture suggestive of corkscrew esophagus. One of the important differential diagnoses when only chest pain is there is angina or MI. Angina, MI, we have already discussed this one. Now, as far as the diagnosis is concerned, prolonged ambulatory esophageal manometry means manometry we will have to do, and we must correlate the manometric finding with the episodes of chest pain. If that is correlating, yes, diagnosis can be made. Diagnosis can be made by these two important findings. As far as the treatment is concerned, there is no proven pharmacological or endoscopic treatment that is effective in diffuse esophageal spasm on a long-term basis. But yes, for transient short-term effects can be seen with calcium channel blockers like nifedipine or vasodilators, and sometimes yes, endoscopic dilatation. In these type of patients suffering from diffuse esophageal spasm, the chest pain and dysphagia, if both are present, usually patient stops taking proper nutrition. Finally, the end result is a malnourished patient. The surgical treatment, the extended esophageal myotomy up to the aortic arch level. We must do an extended esophageal myotomy. Yes, this can help us in diffuse esophageal spasm. But if the patient is suffering or complaining of dysphagia in diffuse esophageal spasm, and if we are opting for surgery, very good result. But if the patient is only complaining of chest pain, the result may not be so good. So always we should pay attention and be very careful when only the chest pain complaint is there and patient is asking you for some surgical intervention. Please just avoid it, because even after surgery, that is not going to help the patient very much. So the take-home message is diffuse esophageal spasm with dysphagia, with or without chest pain, do the surgery. Diffuse esophageal spasm only with chest pain, with no dysphagia, avoid the surgical process. Now the second condition affecting the body of the esophagus, the Nutcracker esophagus. In this, just try to understand, Nutcracker esophagus means suddenly the pressure inside the esophageal lumen will become very high, more than 180 millimeter of mercury. It causes chest pain. Whether it's a disorder or not, it's intermittent. So the important thing is always differentiate this condition with MI or angina or some other GI disorders. These differential diagnoses should be taken care of. Not very much the etiology and other things are known about this condition. Next group is the autoimmune diseases affecting the esophagus. especially seen in systemic sclerosis. Other conditions, yes, polymyositis, dermatomyositis, the systemic lupus erythematosus, the polyarthritis nodosa, the rheumatoid disease, all these autoimmune diseases, the esophagus sometimes may get involved. And these type of patients, most of the patients, usually there is weak peristalsis of esophagus. And dysphagia is, usually associated with pharyngeal problems in conditions where the primarily the skeletal muscles are being affected. For example, polymyositis. So dysphagia along with pharyngeal problems due to affected skeletal muscle. Example, polymyositis. Or another scenario could be dysphagia with extraesophageal problems like involvement of cricoarytenoid joint in rheumatoid disease or dry mouth in Sjogren's syndrome. These could be the presentation. In systemic sclerosis, the smooth muscle usually that is atrophied, causes hypoperistalsis of the esophagus, and there is loss of anti-reflux barrier. Why there is loss of anti-reflux barrier? Because lower esophageal sphincter is involved in systemic sclerosis affecting the esophagus. There is mild to severe dysphagia, and patient usually complains of regurgitation as well as aspiration. In systemic sclerosis, where the esophagus is involved, these patients with severe reflux complain. In these patients, usually due to weak acid clearance, these patients develop ulcers followed by healing, leading to stricture formation. So esophageal strictures are very common. In advanced scleroderma of esophagus, usually the esophagus dilates and there is incompetent lower esophageal sphincter. And here you can see the proximal portion of the esophagus is very much dilated. You can see here. This is advanced sclerosis cases. Motility is disturbed. Till now, for motor disorder, no drugs are available to correct it. So medical management, the basic drugs are the proton pump inhibitors. Why proton pump inhibitors? Because these drugs can minimize the reflex-induced damage that is being done in these type of patients. Autoimmune diseases involving the esophagus. So start with proton pump inhibitors. At least we are minimizing the damage. And few patients, yes, if they are very much symptomatic, they may require anti-reflux surgery as that is indicated for gastroesophageal reflux disease. And finally, the disorders affecting the body of the esophagus, we are having the fourth condition, that is Eosinophilic esophagitis. In children and adults, this Eosinophilic esophagitis can present as an alone candidate, or sometimes it could be a part of eosinophilic gastroenteritis. This is the characteristic finding from esophageal wall, that is eosinophilic infiltration. As far as the etiology is concerned, it could be allergic or sometimes idiopathic, no cause. Dysphagia is the commonest presenting symptom for these patients, and almost more than half of the patient, they give history of atopy. Then on endoscopy, upper GI endoscopy, the esophagus is narrow and very friable, and there are presence of mucosal rings. Various mucosal rings we can see with narrow esophagus and friable tissue. In these patients on endoscopy, we can see the deep ulcers leading to stricture development, and stricture, especially in proximal esophagus, that is there. The proximal esophagus is most commonly affected in these patients, and by taking endoscopic biopsy and sending it for histopathology, the diagnosis we can establish. As far as the treatment of this eosinophilic esophagitis is concerned, for short term, just eliminate the things in the diet that you think, yes, I am allergic to this particular thing. Just kindly eliminate that particular tables. As well as topical and systemic steroids can be given to the patient. Nowadays, the anti-interleukin 5, that is immunotherapy directed against interleukin 5, it's a very promising approach under study, and this interleukin 5 has a very major role in eosinophil recruitment, and if we are going to block this interleukin 5, yes, we can help these type of patients. When all these medical management and other things, they are not going to work, then we can go for endoscopic dilatation. But the disadvantage of this procedure is it can further create deep ulcers and further scarring, leading to again further strictures. So it should be used very cautiously, this endoscopic dilatation, when all the medical management is not going to work. And this is the third group, the pharyngeal and esophageal diverticula. The first group was the disorders affecting the pharyngo esophageal junction, followed by disorders affecting body of the esophagus, and finally this is the third group, and the final group, that is pharyngeal and esophageal diverticula. Now in this group we are having 4 subgroups, just for your understanding. The disorders affecting the upper part of esophagus, disorders affecting the middle part of the esophagus, disorders affecting the lower part of the esophagus, and disorder affecting throughout the esophagus, or it can affect the esophagus in a diffuse manner. Let's start with the upper part. The pharyngeal and esophageal diverticula affecting the upper part of the esophagus. So most of the esophageal diverticula, let's start with the diverticulum. Basically in this group affecting the esophagus are of 2 types, the pulsion type and the traction type. The pulsion diverticula and traction diverticula. So what is pulsion diverticula? Basically this pulsion diverticula, they develop at the site of weakness, and they're going to arise due to chronic pressure against an obstruction, and due to increased pressure it just form this pulsion diverticula. Pulsion diverticula, they form due to increased pressure, and it just like hernia, it just come out through some weak point of normal or abnormal anatomy in a patient, especially the cricopharyngeal area. And symptoms are mostly due to underlying disorder. Normally, the patient is symptomatic not because of this small pulsion diverticula. These patients are symptomatic due to the underlying disorder, due to which there is increased chronic pressure raised. The chronic in a chronic manner the pressure is high, and it is leading to the formation of pulsion diverticula. So underlying disorder is responsible for the symptoms of the patient. Remember this. Only when these pulsion diverticula, they are very large, yes, the symptoms could be directly allocated to these diverticula. Like in this X-ray film, you can see a large pulsion diverticula. Here you can see. Can you see this? This is esophagus, and this one is large pulsion diverticulum. Large pulsion diverticulum. Again going inside the mediastinum, the thoracic inlet area, arising from the cricopharyngeal area. This is large pulsion diverticulum behind the esophagus. This one is the esophagus. This one is the esophagus. Another variety of diverticulum, esophageal diverticula, is the traction diverticula. Remember, this traction diverticula, they arise due to some chronic granulomatous disease. There is fibrosis, and again traction is there, like in pulmonary Cox or tuberculosis, due to some atypical mycobacteria infection, histoplasmosis. These are the diseases that can give rise to development of traction diverticulum. These diseases, they usually affect tracheobronchial lymph nodes. There is fibrotic healing of lymph nodes, and these fibrotic bands, they exert traction on esophageal wall, leading to formation of focal outpouching in a small conical shaped manner, leading to formation of traction diverticulum. These type of patients, they are also complaining of sometimes broncholithiasis, presence of stones in the bronchus. And sometimes in neglected cases, some complications could be there in the form of aerodigestive fistulation. There is communication between gastrointestinal tract, that is esophagus, and the respiratory tract, that is trachea. Tracheoesophageal fistula could be there as a complication, and sometimes massive bleeding. These could be the presentation of these type of patients. One of the very common example, so as PG point of view, the Zenker's diverticulum, also known as pharyngeal pouch, not really an esophageal diverticulum. Why? Because this diverticulum, it protrudes posteriorly above cricopharyngeal sphincter through the dehiscence of Killian, a natural weak point in human beings in cricopharyngeal area, above cricopharyngeal sphincter, through the dehiscence of Killian, between the oblique and horizontal fibers of inferior pharyngeal constrictor muscle. This is an outpouching through this natural weak area. Exact mechanism, yes, we don't know, but yes, one thing is certain, that it involves loss of coordination between pharyngeal contraction and opening of upper sphincter. The pharynx is not doing contractions in coordination with the opening of upper sphincter. This is certainly one of the cause for development of Zenker's diverticulum. As you can see in this diagram, these are the thyroid gland, both sides. We are looking from the posterior aspect. This is inferior constrictor pharyngeal muscle. This is esophagus, the recurrent laryngeal nerve by the side, and here the cricopharyngeus muscle is there. This one. Here you can see 3 gaps, 1, 2 and 3. The first one is known as Killian's triangle, this one, through which this Zenker's diverticulum is coming out posteriorly. We have just seen an X-ray also, a large diverticulum coming out through this portion. Then the second one, this area is Killian-Jamison's area, and this third one is Lambert's triangle. So just go and study these anatomical landmarks after going through this lecture if you want. As far as Zenker's diverticulum management is concerned, if a small diverticulum is there, it only tells us that there is some incoordination with pharyngeal dysphagia. There is some incoordination with pharynx contractions and opening of upper esophageal sphincter. So in these group of patients, pharyngeal dysphagia is a predominant symptom. Whereas as the pouch, this pharyngeal pouch enlarges, this is going behind the esophagus and it tends to fill with food on eating. And finally the fundus of this pouch, this descends into the mediastinum, and the patient usually, there is halitosis and started complaining of now esophageal dysphagia. So two types of dysphagia, pharyngeal dysphagia and esophageal dysphagia. Now this, the enlarged pouch, the pharyngeal, the Zenker's diverticulum, it is going to affect the esophagus also. There is difficulty in swallowing at the esophageal level. Halitosis means bad breath. The endoscopically, we can use a linear cutting stapler to divide the septum between diverticulum and upper esophagus, and we are going to join both of them, producing a diverticular esophagostomy. This is the treatment of Zenker's diverticulum. And if this technique is not available, the laparoscopic route, we can go for open surgery, and these are the three things we are going to do. The pouch, excision of that Zenker's pouch, the Zenker's diverticulum, followed by suspension. We can go for pouch suspension also if you are not going to excise it, that is diverticulopexy, and or means if required, the myotomy of cricopharyngeus muscle can be done. All these techniques, they are having good outcome, equivalent results. Now the middle part of the esophagus, the mid-esophageal diverticulas, they are there, and usually the small pulsion diverticula, usually they don't create any problem, and even the underlying motility disorder, it doesn't require any treatment. So mid-esophagus, if there is a small pulsion diverticula, no treatment is required. But yes, in some patient, especially with traction type diverticula in granulomatous disease, the patient may present to us with a fistula between trachea and esophagus, and in that case surgical treatment is required. So take home message, if pulsion, no treatment required. If traction type diverticula in mid esophagus presenting to us with tracheoesophageal fistula, surgical treatment. Here as you can see, the traction, the granulomatous disease, this one is esophagus, and this was the disease. This is a traction diverticulum leading to formation of tracheoesophageal fistula. Complicated case. So surgical treatment is indicated in these type of patient. The lower part, known as epiphrenic diverticula, very important. The variety of pulsion diverticula, especially affecting the lower esophagus above the diaphragm. Sometimes it may become quite large. The smaller one, they are not going to, sometimes they not give any symptoms. Patient is usually asymptomatic, but yes, if they are large, they can be symptomatic. There is loss of coordination between an incoming pressure wave and relaxation of lower esophageal sphincter. Now remember, we are discussing the lower part. So in coordination between the pressure wave, the peristaltic movement, and relaxation of lower esophageal sphincter. For a small diverticula, don't do anything. For large diverticula, it should be excised, and it can be combined with a myotomy from site of diverticulum, even sometimes up to the cardia, to relieve the functional obstruction. The epiphrenic diverticula. In this particular condition, please do not treat only the diverticulum. Why? Because this diverticulum is usually associated with lower esophageal sphincter dysfunction. This is most important point we should take care of. We must treat the associated lower esophageal sphincter dysfunction also, if that is there. These diverticula, they are just indicating that there is a motor disorder, some motility disorder is there affecting the esophagus, but sometimes they do not cause symptoms. The symptoms is because of this lower esophageal sphincter dysfunction. So take care of this. Like in this imaging study, you can see the epiphrenic diverticulum. There's this esophagus dilated part, and this is the large epiphrenic diverticulum, or large lesion sitting, mass sitting just above the diaphragm at the lower esophageal sphincter site. And finally, there is a condition known as diffuse intramural pseudodiverticulosis. It's a very rare condition, and there are multiple tiny outpouchings there. During endoscopy, we can see from lumen of esophagus. And pseudodiverticula, these are basically not a true diverticulum. Pseudodiverticulum is basically dilated excretory ducts of esophageal sebaceous glands. Yes, esophageal sebaceous glands. Very rarely, esophagus may have ectopic sebaceous glands tissue. So remember this. Normally, esophagus doesn't have sebaceous glands, but sometimes ectopic sebaceous glands can be there. More commonly, it is affecting the lower part, but yes, it can affect either the upper or the mid or the lower part esophagus. For this condition, no treatment is required. So that is all for this topic. Stay safe. Thank you.